So I just want to remind everyone, well, welcome everyone. Rachel and I wanted to remind all participants that the deadlines for ELOs are February 15th, correct? As if we are wrong, Jackie. We were not sure about the exact day of the month. And then for the proposals for the conference, I think is March 15th.
March 15th for the proposals and the ELOs, I think was a week later, but I'll check.
Can you check both? Thank you. Right, so were there any other announcements that we had to make today?
I mean, I think just everyone's here, so this is great. Or people here know that we've changed the times to the first Mondays of the month, so that will continue moving forward.
Yes.
Yeah.
And February 17th for the ELO.
Okay. And the proposals was
March 15th.
Sorry.
15.
It's
Birna,
Berna. I
Hi,
was
Berna.
just going to jump in. There is a lot happening right now on the advocacy for collaborative care to get passed in a lot of the state Medicaid. So if people know people or live in Maryland, Oklahoma, Arkansas, Maine, there are active bills being reviewed and people are testifying and readings happen as we speak. So if people are from any of those states or have strong connections in any of those states, reach out to me, and it'd be great to have people involved in the advocacy.
That's awesome. Thank you for saying that, Virna.
Great, that's good news. Okay,
Okay, I
guess-
think you can start, David.
all right, well, let me begin with a brief introduction. My name is David Haddick. I am the CEO of a company called Psychoanalytics. I dove into behavioral health care with a history of product development, product design in Medicare and medicine, healthcare. And I've been involved now for about 8 years. My goal is to learn enough to build technology to expedite the expansion of integrated care. We have a great team of people who are very dedicated, but we're very small. And the market consists of over 100,000 primary care clinics, many of whom are embarking upon some form of integrated behavioral health. So, that's what I'm looking for. That's what I've been gaining from my membership in CFHA and many of the SIGs that I'm involved with. Currently, Naftali has organized a work group composed of half a dozen companies that are members of CFHA. All of us have some form of electronic assistance and computer automation to offer to the market. So clearly screening is the easiest thing to actually automate. And I used my company's technology to deliver this the survey tool to the Boise conference. And I confess to having a somewhat hidden agenda. I just want people to get exposed to doing screening on their smartphones, because I do think that's the future of automated in the screening process. And so to complete the questionnaire, over 100 people had to do it on their smartphone. And the surprising thing to me was how many people spent a great deal of time typing in additional information into their smartphone to enhance the results of the survey. And so I appreciated that, and also confirmed it. The smartphone interface is really our future. So most of our technology will be delivered with some sort of handheld device, I believe. Let me just clear out a few things on my, there, no more room on my screen.
If I can, David, as part of your cheering fan section and support, let me just expand kind of the context of why we did this. We, as a work group, have been asked by Naftali and the board to really eventually issue a set of recommendations to report on, what outcome measurements might be used more broadly and supported by CFHA and people doing integrated care. And so we, before we do a review of the literature to understand what we might actually recommend, we wanted to get some sense of what the membership was actually already doing, what measures they were already using. And so there's multiple aspects of this, not only the measures, but also how it's collected, how often, and so forth. So we have sent to the board of CFHA kind of recommendations of next step forward. But this survey that David's going to review is really one step of just trying to understand what people are doing. But it's a relatively small sample of 108, 110 folks.
Yes, thanks, Bill. It's easy to get lost in the distinction between screening and outcomes. And I'll get into that just in a few more minutes. Just to scope out the survey results, 108 people responded to the survey, 5 of whom responded to tell us that they don't do any screening at all. So we had 103 people who reported screening and described their screening efforts. And 12 of those 103 completed the questionnaire based on an outreach on the listserv. So of those 12, we don't know whether they were at Boise or not, but in general, they were no different than the people who responded in Boise. The roles that people reported who responded are shown in this table. Behavioral health clinicians, 57, behavioral health director or manager, 45, administrator, 10, and then other roles of small number of interns, trainees, and then individual researcher, physician, public policy, therapist, and so on. So the total respondents in practice in behavioral health are 89. So we can't speak to what this means in terms of the sample based on total membership, but it puts the context of our results strongly in favor of people who are hands-on with patients. I think that's an important thing to know. The subject of today's discussion is the pediatric results. But before I jump into that, I want to just continue to give you an overall understanding of the information we received. So this table on the left identifies the frequency of respondents selecting a category. The questionnaire was organized by category with several checkboxes under each category that people could endorse for the screeners that they use. And then there was a text field where they could add on screeners that we didn't list. We couldn't have pages and pages of checkboxes, so we were trying to be economical in our screen size. But you'll see here that depression is 94%. So everybody's doing depression, almost everybody's doing anxiety. And then substance use, those are the top 3. Now, pediatrics was a category just like any other category, like depression or anxiety and so on. And it turned out it really needed to be its own survey. But 74% of the respondents, 80 people, did endorse the fact that they do pediatric screening. So what this means is that almost everybody in the behavioral health clinician role has to deal with adults and children. And I think that's a very important consideration. Moving down this line, trauma was next. Cognitive function jumped up as kind of a surprise to me in any case. Quite a number, 2/3 of the people are doing using some sort of tool for cognitive assessment. Okay. The other thing there were 2 other things on the negative side that were interesting to us. First of all, the number of people who don't do screening. Okay. The quality of life screeners are almost not even thought of. So we're in an outcomes group. We're trying to figure out how to measure outcomes. And right away, nobody's measuring quality of life. basically. So, and that should be one of the strongest signals for outcome. We'll see. But mania, eating disorder, mobile screens, and so on. These are the percentage of respondents who just don't do any screening in these areas. Okay, and of course, you get to the bottom of the list. Nobody is not doing depression, and nobody is not doing anxiety. So this complements the previous table. Just a basic question: do you screen for outcomes? No was 51, yes was 42. And then some people just didn't answer. What we're looking at is, perhaps in our recommendation in the future, we want to endorse screeners so that the majority of people are using the same screener. That way we can get statistics that can be used across the industry, regardless of the location of the screening. So these domains had a small number of screeners. ADHD had only one screener, ASRS. Anxiety had the GAD-2 and GAD-7. Bipolar had the MDQ. Cognitive function had MoCA and MSE. And depression had the PHQ, CSSRS for suicidality, and EPDS, which I'm sorry, I'm not that familiar with. Substance use, 2, audit and DAST, alcohol and drugs, and then trauma. So in these categories, with a little bit of a push, we could probably get some standardization across the industry. The other thing Bill just mentioned was, when do people do screening? We had check boxes of before arrival, in the waiting room, in the exam room, after treatment, and so on. So 60% of the people did screening in more than one time or location. Before arrival, of course, the greatest number was in the waiting room and during the appointment. And this is significant because these two categories become bottlenecks to screening and assessment. The waiting room is a crazy place to try and do screening. Patients come late, schedules get moved around, people get called in early, and it's just a chaotic environment where it's very disruptive to try and get the admission staff to also do screening. And then during the appointment, that's a direct conflict with working with the patient. Although I realize screening is part of working with the patient. But if you only have 20 minutes and you spend 10 minutes on screening, that gives you 10 minutes to deal with problem solving. And then again, the sad part is after treatment, almost nothing is happening. Okay, so now let's get on to the meat of the conversation, which is difference between adult and pediatric screening. But before I jump into this, any questions about what I've said so far?
David, could you say a little bit more about the ASRS for ADHD? Or what does the ASRS stand for in that context?
The ASRS, Dave, is it okay if I jump in?
Please.
Yep, it's an adult screener for ADHD. So if we're folks here on the PEDS world, probably not going to be familiar with it, but it's the adult self-report measure for screening for ADHD.
Great, thanks.
Yep.
And I want to speak to that from personal experience because my son is an adult with taking medication for ADHD, and both of my grandkids are taking medication for ADHD, and they're age 8 and 12. So there's apparently the latest literature shows quite a difference between adult symptoms for ADHD and pediatric symptoms for ADHD. It's almost like it's two different things. So, and again, is ADHD a disorder? I don't know. That's still an open question to us. So in adult medicine, anxiety, depression, substance use, bipolar disorder, and cognitive function, those are the top screeners that are used. I will say that depression is closely coupled to suicidality. So you see here, there's a strong signal for using the Columbia Suicide Severity Rating Scale. And I want to talk more about that in a little bit into the future. Over on the pediatric side, we have the PHQ-A as the dominant, as is the Vanderbilt and the ASQ. ASQ is asked now, ask 30 questions. It is not ages and stages as I first assumed. So anyway, so that's a suicidality screener. And it's commonly used, I would say. So that is very appropriate according to the literature that we've seen. Of interest to me is the PROMIS tools. PROMIS is development of NIMH. It's free, it's well validated, and it's extensive. I think now there are 400 PROMIS scales as individual diagnostic tools, and they encompass behavioral health and medical as well. And they are getting some traction here in pediatrics, which is good to see. The Columbia is further down the list in pediatrics compared to adult medicine. And surprising to me, ACEs is just not there. And you can see the diversity of screeners that were reported, and these were all entered manually. That's what this column on the left means. It says manual entry. That means it wasn't part of the checklist under pediatrics. It was added in the free text field. So there's quite a bit of diversity in our population using different screening tools. Anyone care to comment on either the frequency of use of some of these pediatric tests or the comparison to adult medicine? Remembering that most of the people are doing screening in both sides of this page.
I can offer a comment, Dave, if that's okay. I
Please.
think one thing that I would keep in mind is that my guess is that many of the folks who responded to the survey, given that it was put out by the primary care behavioral health special interest group, might be practicing primary care behavioral health. And that model, of course, is going to be lifelong care. So it's care across the lifespan, meaning that those folks are going to be practicing with both kids and adults. So that might be partly why our data is showing good responses on both sides. I'd be curious for the group here, for folks that are practicing and have a stronger interest in PEDS, are we missing anything, or does this feel representative of your practices?
Thank you, Lisa, for your comment that there isn't much developmental social emotional screening.
Mm-hmm. Yep. That's a good point.
I'm sorry, it's just I couldn't quite hear you.
That there isn't much developmental socio-emotional screening given the right food recommendations. So yes.
Yeah, that's a good point. We didn't get any manual entries for those. Not many anyway.
Looks like a couple for the
Mm-hmm.
SWIG, but,
Yep.
but not very robust considering what Great Futures is recommending.
Right. That's a good point. I appreciate that.
Yeah, I'd appreciate it if somebody could put that in the chat because I'm not tracking the conversation. Sorry.
No, that's okay. It's in there, Dave. It's in the chat. I think the Bright Futures is that would be a great whole other category of things to know, right? Who's using that? How are they using it? You know, all of that too. I know in my clinic, that's been a long process getting it all put into place. So I appreciate the comment on it. I think that's good.
Right. Okay. Just remind me to save the chat before I go any further.
We will save the chat, David.
Yes. Okay.
There is something that caught my attention on the previous slide. The social determinants of health screening was also pretty low.
Mhm.
Yes, I didn't focus on that. I don't know, does that seem like a good number for you, or 35%?
I think, I mean,
Or it seems pretty low to me,
it
considering
does. Yeah.
Mhm.
all of the publications on social determinants of health and what we know about how they control health outcomes.
Mhm.
Yeah.
Did people
But-
report any specific, going back to the top screeners, any social determinants of health screeners?
Yes, I can look that up for you. I didn't put it into this summary.
Mm.
Hang on just a second. Let me go get that.
That's a great question, because I think most of the screeners that we had people talking about were more symptom based,
Mhm.
which makes sense, because I think that's where a lot of organizations have pressure to gather those kinds of things, for organizations that have to do reporting out to different types of groups, HRSA or whatever else you have to report
Right.
out to. I think that some of those measures are going to be
Okay.
more support from administration to be getting those going in the clinic. But the social determinants of health, I agree, it's an interesting category to be taking a look at, as well as the difference between screening measures and outcome measures as well, right? I think a lot of places are doing pretty well at screening, or at least better at screening than with outcomes measures. And there's a lot of reasons, I think, why. But I think that was something else that we saw with this data too.
Right.
Okay, so what's on the screen right now, and I'll make it bigger. Okay, this is the response to the questionnaire about social determinants.
I think
We
we're
are still, yeah, we see the other screen. That happens when you share a screen that doesn't go with you.
Okay,
might need to stop sharing and share again.
very good. Okay, so as I mentioned, first of all, I'm curious, how many of the people here today completed the questionnaire in Boise?
I did.
Thank you.
Well, then this is good, because you're getting new information. As I said, the questionnaire was organized by domains, and each domain was had a series of checkboxes. Every domain had the checkboxes that we do not do screening in this domain. So as you see, that was the majority of the responses. Out of 72 total responses at the bottom here, 32 people said, no, we don't do it. The greatest number of tools used was prepare, which is perfectly understandable, followed by the Duke and this OQ. I'm sorry, I don't know much about it. One of the things that we were interested in is how much had screeners migrated into EHRs. And Epic is probably doing a good job of supporting screening tools. What I'm concerned about, maybe it's just me, is that as whatever the EHR vendors invest in, because it does cost them money to add a screening tool to their product line, it may not be based upon best practices, may not be based upon any visible understanding. We could wind up with Epic and others putting a few popular screeners in and then saying, fine, we've done our job now. As you can see from the data we've collected, we need a lot of screeners. And if the most convenient way to do them is in the EHR, then we need to get EHR vendors on board to do that. So anyway, this is the answer to your question.
Thank you, Dave.
And the other thing it shows is that this is a very nascent field. As such, there's a lot of variety in how people are approaching the question, and a lot of creativity and individual effort is being put into figuring out how to do this. So it's not settled law, as they would say at this point. So there's a lot of room for growth here. And the prepared tool, I have it in my library. We use a bit of it. It's like a lot of these social screeners. They express a point of view that's kind of negative in the way the questions are posed and the questions that are selected. So when we're talking about equity in healthcare delivery, it doesn't help sometimes to ask questions that put people off. I just want to make a note of that from my personal experience. You know, there are questions that literally like, you know, how often do you beat your wife in some of these social survey tools I've seen. I'm using a, you know, a cute example, but they're, you know, they're tough. They're tough questions. How many people in your family have been incarcerated? Or how many people in your family are presently incarcerated? These are valid questions, but they're hard questions to ask.
David, I'm not sure how much time we're given for this group, but one of the things, actually, there's two questions I have and would like to get people's input on this. First of all, what's the level of motivation at your clinic, at your institution, to expand screening? I mean, is there any momentum for that? Is there a frustration that it's already too much? Where's the state of your clinic, your clinical sites in terms of school?
That's good.
If people want to put answers in the chat, if you don't want to unmute, that's perfectly fine. But if you can answer the question, that would be great for the discussion.
The other question I have, and I'm famous for asking compound questions, but another question is, what would be most helpful to each of you to improve outcomes measurement? What do you feel is needed from your perspective that CFHA could do to support your efforts in measuring the impact of what you do?
I'll say a few things about both of those questions. One, I would think that it often depends on, sort of the question about motivation and how many practices are doing it. I think often depends on some of the requirements, right? Whether we have Medicaid or other insurers who are requiring screening rates and reporting data. So I think that's one thing. But I think in terms of how to get practices more engaged and motivated, it's the age-old question, I think, of time and money. And I think if it were easier to do and easier to pay for, I think many practices would be more on board. So maybe advocating in terms of how to pay for those, that insurance companies are paying for screening and the time that it takes to administer, review, get it in an EHR, and all the things that we've been talking about today.
Mm-hmm. Okay.
And it looks like people are putting in the chat that there's screening fatigue, probably related to what Lisa's discussing, but they give a lot of screeners.
What's people's sense in terms of the use of is when people are screened, how is it being used? Or does it feel like it's just being, a number put in the EHR and never used again, or never used to guide care?
I think for us, for our organization, the electronic use of the screeners made a difference, both in motivation, completion rates, and ability to follow up, monitor through the screeners. What made that difference for us was the pandemic, when everything had to be rethought in terms of access via my chart for visits. That also facilitated sending the screeners that way. So it was a huge organizational effort around having them automatically go to the patients prior to visits. I think that was a huge factor for success. We have currently more than 90% of completion of behavioral health screeners at well child visit. So
That's
That
awesome.
sounds wonderfully high.
Yeah,
It
that's
really does.
amazing. I'm a little jealous over here. Yeah,
but
comments-
our first screener is the PEDs 17, and that triggers, after that, depending on the responses, it triggers the PHQ 8 without the question 9, because we asked that question in person at the visit, and the GAT7. And I was also looking at these results, and I might have missed how many people use the, there it is, the PSC 17. 26.
Yeah, it
Yeah.
ranked 4th in the list.
Yes.
So this leads me to another really hot topic for us. Is it worthwhile to use a diagnostic type screener as an outcomes measurement? It's become almost standard in depression to use the PHQ-9 or the PHQ-8 as a marker for treatment progress. So, and it leads to the term treatment to target. So if somebody's scoring 12 or 15 on the PHQ-9, and a couple of weeks later they're down to 5, that in some circles is counted as remission. And I wonder if that's really, if people think that's the way to go, compared to the target that most behavioral health clinicians have, which is to improve mood, engagement, and ability to deal with life's regular problems. Because, depression shows up as a result of many different effects. So if you're just measuring the depression with the depression tool, are you really getting at the success of the patient in self-care? I don't know. So that's one of the things we're concerned about. Does that ring true to anyone in the audience today? Well, anyway, it is of concern to me and a few others, I guess, that we aren't measuring the same qualities that we use, that we collect when we do a contextual interview.
Right. And this is the comment that Matthew is putting on the chat. Have to pair the screener results with a solid understanding of the patient and family context. Yeah. That's, I guess, a risk with any screener, right? That it gets contextualized as a tool. I mean, just used for the sake of using a tool, perhaps as well, not as part of an interview process. And I have to contradict what I said before when I think that, because when you send it automatically, is devoid of the context, absolutely, and of the interview. So how did you incorporate it in the visit as part of the interview or the visit? Yeah.
Right. I'm familiar with the screener fatigue that people feel, because every time I mention screening to someone, they immediately think of sitting down with pencil and paper, and collecting the data, scoring the data, evaluating the data, and entering it in the EHR, which is busy work. And as a computer guy, I don't think we should be doing busy work. I think the computer should do the busy work. But that's my personal bias here. But I do think that the labor content gets in the way of screening. And so one way to look at these results is, wow, we're doing an awful lot of screening in spite of the hardship it imposes upon our time. So in one sense, the glass, it's the old glass half full or glass half empty. It looks to me like the glass is half full, just because of all the screening that is being done. Wouldn't be done if it wasn't beneficial and worthwhile and reinforcing. So that's, so
I
yeah,
don't know if this question is relevant to you, but it is to me, so I'm going to ask you. How many of you in your roles as behavioral health clinicians are trained your pediatricians or your other staff to utilize the screeners?
I'm definitely involved with that at my clinic of training. It's a part of behavioral health's role is being involved with, we were involved with Bright Futures rollout. We've been involved with other universal screening protocols and things like that. And the screening fatigue has been a real factor for us too. And one of the things that our feedback from our medical providers is, can we narrow it down to a few? Do we have to do 10? You know, how do we parse it down so that we're getting the most important ones, was their request, which is a really difficult question, of course, to answer, because you don't always know which direction to go until you're talking to the patient. So it gets to be a complicated one to answer. And I think for myself, one of the things that this has brought up too is the fact that I would really love to have a measure that was more universal, that could be used for outcomes. And I don't think we have anything like that that's quite as universal, you know, across diagnostic categories and so on and so forth. So I think there's areas of potential growth and, you know, research, and for people that have an interest in developing those things, I say, please and thank you, have at it. And that'd be great to have things that could be involved in primary care.
well, I want to respond to that because there is a screener called the Outcomes Rating Scale. It's about 20 years old, that attempts to measure a universal attribute that could be considered outcomes. When I first came across that, it was strikingly similar to the contextual interview from FACT. Exactly the same domains. And in talking to Patty Robinson about that, I was kind of surprised that in the way she teaches FACT, there's never a repetition of the contextual interview. It's done once, and for the most part, they don't address that again later on, unless maybe down the road there's a new visit and they would do it again. But right there is a tool that could be handy for measuring the overall quality of life in four simple questions that you're already using. It would just mean, okay, in the final visit or a follow-up visit, go through it again and keep track of the differences. Now, okay, so there's something else we need to talk about because we're interested in outcomes. That's our goal. We are all more or less born and raised in the context of medical outcomes being the remission of symptoms. I have a cold today, I don't have a cold tomorrow. That's a positive outcome. And it seems to me that the majority of discussion about outcomes follows that medical model. Like I said earlier, if your PHQ-9 scores drop, okay, that's a reduction of symptoms. But is that really appropriate in behavioral health? You know, we know that in abuse, it takes 4 or 5 tries to succeed in reducing the use of addictive substances. Well, are those first 4 attempts failures, or just part of just one step on the path of progress? And it's important because we're talking about moving into value-based care, pay for performance, and all these things. I know it's a 20-year-old conversation, and we think it's never going to happen, but it's moving. It will happen. So if the payers are imbued with the medical model. And they now start looking at behavioral health. Are they going to get impatient with the fact that, we don't have a clear demarcation of an outcome? The virus is gone. Okay, that's an outcome. The screening image shows no more cancer. That's an outcome. But we don't have that. We don't have a lab test for most of our behavioral health issues. It's a process. And I'm concerned, and I want some feedback from this group about that idea. How do you consider a successful outcome? And again, the PCBH model says, come back anytime. Just the door is always open. Come back, and we'll help you again. So are we going to be creating a problem as we switch into more outcomes-based reimbursement or capitation models? If this is a new thought or new conversation, that would be great. I hope it percolates and you think about that, because to my way of thinking, it's important that we understand behavioral health is much different than medicine. You don't take a pill and get better in a couple of days, as you know.
I think that kind of speaks to just what you were talking about earlier, the importance of being able to monitor people's functioning too, and like practically what is helpful for them, not just symptom reduction, but being able to do things in life that are important to them. I think there's probably some crossing though between the work we do in primary care and even medical outcomes though for people, in terms of working on adherence to, medical regimens and things like that, through our focused interventions, it may be impacting physical health outcomes as well that we're not tracking through behavioral health screeners, but, that are helping people with their blood pressure and their weight and their, cardiac health and all sorts of things like that.
Yes, that's a really important aspect. And yet that's even more difficult to track.
This is a great discussion, and David, I want to thank you and Bill and Megan for presenting all the information today and kind of opening up and letting us percolate a little bit more about what are the outcomes that we want to measure above and beyond, symptom changes. I did want to leave room for Jonathan. He's going to be presenting a research corner for our last few minutes. So I wanted to kind of redirect us over there. And thank you all for kind of your presentation. And I'll say I'm looking forward to the next steps, because I heard that you're going to be, presenting us with some recommendations coming soon. So I know we'll look forward to kind of hearing about the full report that you're going to be presenting.
I'm not sure about the soon part.
Thank you for having us. We appreciate it.
Yes.
Yeah.
Thank you much.
Yes, thank you very much, David and Megan and Bill. A lot of great points you guys brought up, and I agree with the philosophical points, David. And some of the questions that Megan and Bill asked, I kind of asked myself as I was creating this PowerPoint. So let's see, I'll just share this real quick, and I think it's probably a better discussion to be had about this. So this was can everybody see it? I take it? So this was a systematic review of pediatric primary screening measures. And really classification accuracy was measured by sensitivity and specificity. So what they did is they looked across 3 databases, and the primary keywords, or the keyword searches, were screening, primary care, behavioral problems, emotional problems, psychopathology, behavioral screening, children, adolescents. They also tried to capture kind of computerized aptitude testing, and other ways to catch the diamond and promise, which didn't necessarily fall into some of this other criteria. And again, classification accuracy was measured by sensitivity, the percent of individuals with the disorder who are correctly identified, and specificity, the percent of individuals without a disorder correctly identified. And here's kind of a flow chart here. And one of my main critiques of this was that they ended up with just 10 reviews. And my understanding is these were all the reviews were between 1991 and 2013. And this was published in 2016, this article. So I think there's a lot of other measures, as David was alluding to, maybe it's more computerized technology potentially, or the promise that this systematic review did not capture. With that being said, from the 10 reviews, 26 measures were identified as being prevalent or popular, and 5 measures. Here are the measures: the child behavior checklist, the pediatric symptom checklist, strengths and difficulties questionnaire, brief infant toddler social emotional assessment, ages and stages questionnaire, social emotional scale. And they did try to cover these to some capacity. So what they used as the results, basically, they made this criterion of when sensitivity and specificity were both above 0.7. And in the literature, they often recommend 0.8, but they gave a great explanation, basically why they chose 0.7. So I encourage you to look at that. And there's so much exclusionary criteria that I encourage you to further review as well. So in terms of the results, basically, they found the child behavior checklist met this criterion half the time. So this was widely used, but it tended not to be effective at identifying both those simultaneously, hence the 50%. The strengths and difficulties questionnaire met this criterion at 30.8% of the time. So just a few studies found that. These two actually had, I guess you could say, they met the criterion most of the time, but there was very few studies and pretty significant limitations, really, especially for this one. As far as a pediatric symptom checklist, this one met the criteria 55.6% of the time, and even did the short form, the 17 item, but had some limitations as well. As far as the other screeners, the computerized aptitude test of the pediatric symptom checklist showed similar high sensitivity and specificity, but with some limitations. Diamond appeared promising, but had limitations. And then the promise, we actually discussed this last time. There's really just not much data on that in terms of classification accuracy. Here's probably the main table in the article, a lot of data here. And again, all this data I shared with you is really an overview. They give a lot of explanation of sensitivity and specificity, but really I was concerned with this overall, above 0.7. And this is really what I reported on here. But I encourage you to look at the article if you want to get more of the ins and outs of this kind of data. So taken together, in pediatric primary care, the child behavior checklist, strength and difficulties questionnaire, and the pediatric symptom checklist across this review, and mind you, between 1991 and 2013, these are the most popular, but still, I'm interested in your thoughts about this sensitivity, to detect, to correctly identify a disorder and to incorrectly, or to identify individuals without the disorder. Was only 38.8 to 55% of the time. And these others, although maybe promising, there's very little data, a few studies, small samples, and So the main takeaways from the authors were that, achieving this criterion is hard. And none of these measures really consistently did it across studies. So at this time, there's not really, they can't really suggest one measure over another. And there's a lot of clinical and practical considerations that go into this. Some of them we talked about today a little bit. Here's some recommendations that kind of fits, training, cost, time, fatigue. So they make the recommendation that, in order for a screener to be best utilized, it should not require significant training or special training. It should take less than 15 minutes, ideally available in the public domain, no cost. And then really the staff, a clinician should really consider the the screening process and decide, what sensitivity, specificity values are acceptable for your clinic. And then I was really going to open up to, really what screening measures do you guys use, and the questions that, Bill and Megan had for you all.
Thanks, Jonathan. That's it's a good overview, and it's interesting. We can kind of open up to reactions that people may have, just thinking a little bit about how this review kind of the outcomes in terms of the screening measures are different than what we got in CFHA's. So I'm struck by the CBCL, just knowing that it's a lengthier assessment to give, and was surprised it kind of comes up in pediatric primary care in this review, and just given that aspect of it.
Yeah, I'd like to respond a little bit to that. I don't think we would have put a 113 question tool into our survey. That seems to be beyond the pale of screening and going into the diagnostic realm. After you've already had the purpose of screening is to identify people who need more evaluation. And I think the CBCL becomes more of a diagnostic tool after you've identified people. And even 35 and 25 question tools are just a bit beyond what we consider to be screening tools.
I'd be curious too, with this study in terms of the, say it's used in pediatric primary care, but what are is this in the context of PCBH or integrated behavioral health care? Like, who's implementing, like thinking about the models and, most of the brief work that many of us do. So I don't know if, Jonathan, you have any context if they kind of described the type of models.
Yeah, so there was an incredible amount of detail and into why they did what they did. And to top of my, there's just a lot of inclusionary criteria here. Top of my head, I can't really answer that question, but yeah.
I have two comments from an engineering point of view. First of all, according to Professor Bays, if we don't know the prevalence in the population, then we really aren't able to compute the positive predictive value and the negative predictive value. Saying something is 0.7 specificity and sensitivity has very little connection to our thinking. If you say the positive predictive value is 95%, yeah, I get that. But these numbers move dramatically based upon prevalence. So when our depression prevalence prior to COVID was one number, and it jumped up 4 times higher after COVID, all of a sudden our screening capability to exclude patients, the negative predictive value, was greatly reduced. Higher the prevalence, the lower negative predictive value you get from your instruments. So these things need to be thought of and included in the research.
I know we're pretty much at time, but I appreciate what I've gotten from this conversation and time is maybe we just need to do a better job when we ask people these questions and differentiate for them the difference between screening, assessment, and outcomes, because there are 3 different things. And I just think of, and again, I don't work with kiddos, but just thinking that, the child behavior checklist is something that I don't know that that's really a screening tool, that you would apply that to every kid who is seen on an annual basis. But that's been helpful for me. So I appreciate the time and discussion. Just kind of differentiating that might be a need, just to clarify when we ask surveys, questions in the future, to clarify really what are they being used for.
Yeah, I think that's a good
One.
point. That was one of the questions that was tinkering around in my brain, but I logged in late, so I didn't know if it was covered. Is even when we say screening, do we mean universal screening or targeted screening? Because I would answer the questions very differently depending on which we're talking about. You know, we're not using the Vanderbilt universally, but we're definitely using it once a concern's been identified from a targeted screening standpoint.
Right.
Yep. Well, thank you all.
Thanks, Jonathan. Well said. I think we have a nice summary that Bill had
Yeah,
there.
there's so much detail in there, and I just captured everything. They talk about pros and cons of looking at it this way. So if you guys like, but thank you again, David, for your presentation.
It's a pleasure. I'm happy to talk to this group. I've enjoyed my other meetings with this group in the past, so I will continue. Thank you.
Thanks everyone. I think we are at the top of the hour and we have saved the chat. So we are gonna get all those wonderful resources from there. Share it in the notes. Rachel, do you want to close?
Yeah, I think we're good to go. Thanks, everybody. Thanks for coming. We'll see you in a month.
Thank you.
Thank you.
Thank you.
Thanks again.